Well, thank you to David for the kind introduction and Sally for organisation. It's great to see so many enthusiastic faces here this morning who've all, as Sally says, have come from so far away. With this first talk in the morning, I'm going to go right back to basics and explain how do the kidneys work in a few slides and spend the majority of the talk explaining what happens when they go wrong. And in particular, from your perspective as a patient or as a relative of a patient, what will you feel as a patient, the kind of symptoms you get? And then, of course, reflect about how we as the kidney doctors might think about these conditions and what we might try to get to do. So, the normal kidney, well, where are they? They're kind of at the back. I was going to try and point to myself, actually, but I've got this stand in front of me, but it's all right. They kind of sat at the back, just hidden by the back of the ribs, really. And in this little diagram, if you take away the front of your ribs, take away the stomach on the left, the liver on the right, and actually take away everything else in the abdomen, you're left with the kidneys right at the back, nicely protected by the rib cage there. As you can see, it's connected to the rest of the body by three things. In red, you can see the artery, so this is carrying blood from the heart, delivering blood, and all the things in the blood, which includes waste products, blood cells, all sorts of things, taking it to the kidney. And the kidney acts as both a recycling centre and a waste disposal unit, really. And what happens is that the things that you want recycled goes back to the circulation, back to the heart and the veins, and the things that you don't want are, well, we know what happens to that. The waste disposal unit, it comes out in the urine. So the waste is processed in the kidney and comes out and drains through these little pipes here, one on each side called the ureter. It's collected at the bottom of your tummy in this little sac called the bladder. When that's full and you feel you need to go, you go to the toilet and the urine comes out of your body. I've mentioned already sort of the main action of what the kidneys do, really, and that's to remove waste from blood to make urine. But the kidneys have other roles, and that's important for us today because when I talk about the effects of kidney disease and kidney failure, it's not just kidney function we're talking about. And actually the kidneys have a number of extra roles, including balancing the amount of acid in the blood that we're all making right now. And it also produces a number of little proteins or hormones, things that actually help communicate to other body systems. For example, renin to help control blood pressure, something called erythropoietin, or EPO in short, and that actually talks to the bone marrow, which is where your blood cells are made, and EPO can actually, and if you don't have enough EPO, you can actually make not enough red cells. And also, the kidney produces a little enzyme which can actually activate something called vitamin D, so you get vitamin D from the sun, and that's healthy for your bones. You see it in the advert, you get calcium in there, and if your kidneys aren't working, you can get problems with that as well. I'm going to focus sort of the mechanism of the mode of what's happening in the kidney, talking in this little schematic which I tried to draw on PowerPoint. How does it all work then? So firstly, you've got the artery here in red, containing everything in the blood. Blood cells, bits of protein, waste products, little salts around the body, and that's all carried through into the kidney. And at this point here, in a special part of the kidney called the glomerulus, the filter of the kidney, the wall of this artery is actually really, really thin. So there's only an inside layer, an outside layer, and a bit in the middle, which you'll probably hear more about in one of the later talks. Across this filter, it's almost like there's little holes, which have to be big enough to let all your waste products out. So when the blood flow comes through at high pressure, you get the waste being pushed through the filter, but because there's salts, and of course the fluid can fit through as well, you actually get lots of things coming out into this filter. And about 180 litres will go across this barrier every day. What happens next is that all of this fluid, the salts, and the waste products comes up through a set of tubes called tubules. And this is the recycling part of the kidney, where you can't have 180 litres of fluid leaving your body every day. It just can't happen. What the kidney is able to do in this tubule is to bring back salt and water, all the salt and water that you need to keep yourself healthy. And that gets taken across back to the circulation, and goes back to the heart as we described earlier. What we're left with, hopefully, is just waste and water, and that makes up the urine, and that goes through the rest of the tubules and becomes urine at the end of the day. So that's all in a nutshell there. It's worth mentioning at this point that I talked about acid balance, and that happens in the tubules. And I talked about the various hormones, the other substances that the kidney produces, and that happens sort of in the rest of the meat of the kidney. And I'll talk about what happens when the kidney fails later on. So now we've got a brief understanding of what happens in the normal kidney. I want to spend the rest of the talk talking about what happens to you as a patient, what we as doctors think about when someone has evidence of kidney disease, and what the doctors will do about it, really. Some of these symptoms you've probably some of you may have experienced before. You may get blood in the urine. You actually notice it as a red discoloration, or sometimes even a Coca-Cola discoloration. And we call that hematuria, simply blood in the urine. Some people may notice of a foamy or a frothy urine when they go to the toilets. And this is because there's protein in the urine, so we call this proteinuria. As a result of there being lots of protein in the urine, the amount of protein in your blood goes down. And some people, as a result, actually get swelling of their body, their legs, the tummy, their arms, sometimes the face when you wake up in the morning. So these are all symptoms we associate with kidney disease. And actually, some people, perhaps not yourselves here, but some people with kidney disease actually make too much urine. They have to go to the toilet far too much, which in itself isn't normal. The important thing is actually some patients actually feel very little in the way of symptoms. So their kidney disease is actually very quiet and hiding. We've talked about symptoms of kidney disease, but there are general symptoms when the overall kidney function gets worse. So when the amount of waste your kidneys are able to remove gets less. This is not a list of all of the symptoms people might experience. That list could probably go on in far finer print, but it's just a feeling of the kind of symptoms that people will talk about. You may feel tired, have low energy, low concentration levels, and this is because of kidney failure as a general, perhaps the buildup of waste products, and sometimes some of the effects of not producing the hormones that the kidney is supposed to make. You may get a poor appetite and perhaps even lose weight as a result of this. You may feel sick, you may actually even be sick. And sometimes if the kidney function is just too little, you may actually start passing less urine. Some patients actually pass no urine when the kidneys have stopped working altogether. The kind of tests that we as doctors think about, so bearing in mind that kidney diseases don't always present with symptoms for you guys, we have to do a few tests, and together we can identify patients with kidney disease. And the first test, the most easy test actually, is the urine dipstick test. And those of you who are patient have probably given lots of samples, and you're almost frowned upon if you don't give a sample of urine when you come to clinic. And the reason why is that if you tell us there's blood or protein in your urine from the redness or the frothiness, we can identify that. But actually, the amount of blood or protein in urine may be too small to see. And we can actually put this little dipstick into your pot of urine, and there's a little chemical reaction that makes a color change. So we can identify how much or perhaps how little protein or urine there is in your sample. You'll almost certainly get a blood pressure test each time you come and see us, and almost certainly, even talking to some of the younger patients here, you will get blood tests. And one of the tests that we're most interested in is something called creatinine, which I probably don't need to explain to many of you in this room. But in a nutshell, it's one of the waste products that we're making, and we're making it as we sit down here. But it's always about balance, so that if our kidneys are working reasonably well, or normally in fact, the amount of creatinine in your blood is usually quite low. But if your kidneys are working less well, the amount of creatinine will go up. So creatinine becomes a measure of kidney function. We're also interested in a whole lot of other simple basic blood tests that we'll often do when you come to see us in clinic. When we see someone with kidney disease, we actually want to know what's going on. And that'll become apparent when, in the later talks, when we talk about MPGN more precisely. And to make an accurate diagnosis, we'll actually then step back and really ask you lots and lots of questions to try and understand why your kidneys are not working quite as well. Because it's not just about the kidneys, these effects can affect the rest of the body, and we can identify lots of different symptoms, lots of different risk factors that may help us explain why your kidneys are working less well. There's often specific blood tests that we'll try and do, some to do with the immune system, which you'll hear about, some to do with the complement system, which, funnily enough, will be very relevant to today's topics. It's not unusual, and most patients at some stage in their diagnosis will get an ultrasound, which many of you will know is a jelly scan of your tummy, looking in particular at what the kidney looks like, just to make sure it looks normal, or is there another explanation why the kidneys don't work. And some patients, many of you in this room, will have had what we call a kidney biopsy, where we take a small piece of the kidney through the skin and we have a look at that under the microscope. As I say, the specific diagnosis and the treatment of MPGN and C3 Glomerulopathy I won't talk about here, and they'll be discussed, I'm sure, in great detail in the later talks. So if there is damage, you all remember this, I'm sure, damage to the kidney, you can get different kinds of problems. We talked about the filter, the glomerulus, which allows all of the, lots to come through. So if you have damage around the glomerulus, for whatever reason, then it's not unusual that more things than what you want come through. So red cells can come through. Perhaps that's why we get hematuria or blood in the urine. Bits of protein can fall through this filter. Again, that explains why you may get proteinuria. If you have a problem in the tubules, so there's some diseases that can affect the tubules, you may get problems with the regulations of how much salt stays in the blood, stays in the urine, or vice versa. And you may get problems with acid balance. And indeed, you may get problems with the ability of the kidneys to recycle a lot of the water. So that might explain why some patients get too much urine. Overall, if you start getting damage to any part of the kidney, so these make up the nephron, the basic unit of the kidney, what you might find is that each nephron starts failing. And as you run out of nephrons, you can't make the hormones that we talked about, and you can't process the blood to make the waste, to excrete and get rid of the waste products. So you get kidney failure. So what's happening in the failing kidney? Each kidney probably has about 1 million nephrons, we think, and they're ready at birth. And all the time, they are slowly dying, but at such a slow level that your kidney function is pretty much normal. And as you know, many patients don't have kidney problems throughout life. And in fact, those of you who are aware of live donor transplants, where you can actually give away a kidney, people who've given away a kidney on paper seem to have pretty good kidney function. They have more than enough spare nephrons. But once the kidneys are damaged, there's scarring, and you start losing nephrons at a higher rate. You're losing them faster than we would like. So you can see the kidney function coming down. And it may be that you get to a point where you start getting more and more symptoms. And the risk of worsening function, so this is kidney disease in the sort of a long term, sort of chronic kidney disease, this risk of worsening function is apparent no matter what the cause of kidney disease, whether it's MPGN or diabetes or because of high blood pressure, for example. And you've got to remember that you might get ongoing damage from your original disease as well. So clearly there's things that, as doctors, we can think about of preventing risk of worsening damage and damage from the original disease. A few years ago, we adopted sort of a way of helping understand sort of the different types or the different stages of kidney disease, and this is a system that's used a lot in general practice with your GPs and a lot by us even in the hospitals to help us explain and help you guys as patients understand the different stages. I've gone straight on to stage 3, but that's where many of the patients with kidney disease will be regularly seen by a doctor of some sort, whether in the hospital or at home. And these patients have 30 to 60% of kidney function, and very rarely actually have any specific symptoms to do with kidney failure, although they may still have blood in the urine, protein to urine, or things like that. If the kidney function gets worse, stage 4 is 15 to 30% of kidney function, and I'll talk about the kind of symptoms that you may notice and the kind of things that we may try to help you with when you're in these stages. It's worth saying that some patients actually remain very well, actually, despite having very low kidney function. All the more reason for us to have to monitor and test your blood, test your urine to ensure that we know where on the path that your kidney function might be. So the patients with stage 3 kidney disease, they'll often see the GP maybe once or twice a year just to check that things are staying stable or not getting worse too quickly. But those who've got worse kidney disease or particular disease like MPGN, you'll come to the clinic far more times, at minimum 3 or 4, and there are some people who come every month or even more frequent. The hallmark of these tests will be urine tests, blood pressure, and of course the blood tests as well. But what we're thinking about and what we want to do is actually slow the kidney disease down, because we don't want you to have symptoms of the worsening kidney failure. And what we'll do for the general treatment is advise, probably less relevant to some of the audience here, stopping smoking. I mean, that's good for all health, but in particular with kidney disease as well. We'll talk about in clinics how we want to get your blood pressure better, how we want to reduce the amount of protein in the urine, and we'll do that by giving you different tablets, such as ACE inhibitors, recommending restrictions to your lifestyle, things like salt restriction. So even in our basic management of kidney disease, we're changing what you have to do day to day. I'm not going to talk about this aspect for MPGN particularly, but stopping ongoing damage from the original disease clearly is important as well. Not all of you here will be in these stages, but if the kidney function as a result does get to 15 to 30%, what happens is you stop producing the right amount of the hormone to give you red cells. So you become anemic, your red cell count goes down, and as a result you can often feel tired just because of that alone. And what we can do is we can give you injections of iron through the vein or EPO, so that's replacing the erythropoietin that your kidneys aren't making. We've talked about keeping your bones healthy, and at this level of kidney failure we can sometimes get problems with a mineral that we call phosphate that's released from your bones. And what we may say to you is we've got to restrict your diet even further. There's certain foods, and again there are food menus that some of you will have come across which kind of cover basically all food types. And you can get phosphate restriction. And actually at this stage we sometimes start talking to you about what happens if your kidneys completely fail. Things like dialysis and transplant, which some of you will have heard of. And today's perhaps not the best day to be talking about these in detail. If the kidney function does get worse, we get to stage 5 kidney disease, and you're at less than, say, 15% or less than 10% of overall kidney function, we start recommending other things. So if you're not getting enough blood through the kidneys, really, as a result, you can accumulate fluid, and that goes onto your legs and into your body as well. And we may ask you to restrict the amount of fluid you take in. So most of us who are healthy will be having free amounts of fluid. If you have kidney failure, you may be told to drink far less. I've not mentioned potassium in great detail, but some patients will be asked to restrict the amount of potassium, so your cheesy chips for lunch will be out off the menu, I'm afraid. Yet more medicines for blood pressure, for the amount of protein, and also just to keep you feeling healthy when your kidney function is low. And of course, these two modes of treatment to basically remove the waste from your blood, because we're no longer able to do that. That's when your kidney function's at the lowest end. As I say, I'm not going to talk about these. Hopefully, in that whistle-stop tour of what the kidneys do and what happens in kidney disease, I'm able just to impart some of the framework for the later talks, that the main job of the kidney is to remove waste from the body, and therefore there are certain symptoms that you may get if your kidneys start failing, that many diseases, including MPGN, will damage the kidney over time, and clearly that's something we have to try to correct if we're wanting to stop patients from getting bad kidney failure. That because of kidney disease and kidney failure, there are different symptoms you may get and many different lifestyle changes as part of the treatment to manage kidney disease, to stop it from progressing, but also to keep you feeling as well as possible. As I say, our aims really are to protect the kidney, and there are many general treatments that we think about for all patients of kidney disease, but really what we're wanting to do and perhaps one of the messages I will take home today is see how we can understand our conditions better and treat, if possible, our underlying condition. And that's all from me. Thank you very much.
Thanks very much, Edwin. I don't know if we've got any questions. Anybody wants to ask to Edwin? Yes, could we have the microphone?
I was just wondering, you mentioned about the dietary restrictions, you went for the phosphate in stage 4, high lipophosphate stage 4, potassium stage 5. Is that what typically happens then? That's when you start worrying about them in those stages?
Sorry, I missed that last bit.
Is it stage 4 you typically start worrying out the iron, the EPO and the phosphate, and then stage 5 potassium, or is that just something that...
It's a rough guide. Certainly if you have kidney function in the stage 3 level, these are generally things we never almost have to worry about. But as you're being monitored and your kidney function is starting to fall into the stage 4 category, stage 5, then the problems that are talked about needing iron, needing phosphate restriction, they start coming into play. And certainly phosphate restriction, maybe as early as stage 4, sometimes into stage 5. It sometimes depends on person to person. But we start thinking about these things. And the importance of what I'm saying is that if we don't monitor, then we don't know at which point you should have started. And certainly in the old days, patients who arrive in the A&E department where the kidneys have stopped working, and basically the phosphates and potassiums are all over the place, you've got fluid all over the place, and patients used to present very poorly when we first found out about their kidney disease.
Thank you.
Any other questions? Back left.
You talk about kidney damage. What's the difference between damage and deposits?
I would say that the way I've used the word damage is just general damage, so it could be because of any manner of causes of kidney failure. So when I'm talking about damage in here, I'm thinking, well, diabetes can cause kidney damage, or high blood pressure. Certain medications that we as kidney doctors see can actually directly damage the cells, for example. When it comes to, and I think that Danny Gale will talk about it more in detail, when it comes to what's happening in the diseases pertaining to us today, then if things can accumulate in the kidney, that in itself can cause damage. So if things that deposit in the kidney, for example, and we can sometimes see that on the kidney biopsy. I hope that clarifies things a little bit for you, but I don't want to give the game away for later on.
Yeah, I think we'll probably cover how complement deposition goes on to cover cause disease in the future lectures, so we maybe just leave that just now. I think we'll move on now. I think all the speakers are quite happy to be approached, so if you have any questions you're too shy to ask NABAs later, also anything, write down, and we'll have a panel at the end where we can discuss any questions you might have. Thanks, everyone.